I'm here to introduce our speaker today, John Epling, who's an associate professor and chair of the Department of Family Medicine at SUNY Upstate in Syracuse. He holds a joint faculty appointment in the Department of Public Health and Preventive Medicine. Dr. Epling has taught evidence-based medicine, public health, and clinical prevention at SUNY Upstate for the past 15 years. He's the founding co-director of the SALTnet, the department's practice-based research network, and through this network, his research has covered a variety of primary care and preventive topics. He has authored evidence reports for the Department of Defense Veterans Affairs Clinical Guidelines Project and has worked with the American Hospital Association in advancing the use of the U.S. Preventive Services Task Force guidelines. Dr. Epling completed the American Academy of Family Physicians Vaccine Science Fellowship in 2012 and currently serves on the Advisory Committee on Immunization Practices Adults Vaccine Work Group. He also recently served on a CDC task force on vaccine inventory management. On the state level, he's worked with the New York State Department of Health's Bureau of Immunizations and served on the Governor's Prevention Agenda Work Group on vaccine preventable diseases. He maintains an active clinical family practice. So join me in welcoming Dr. Epling.
Thanks, Linda. That's a nice introduction. We're going to be talking about HPV, and in a department where Linda Prine runs the women's health curriculum, that's perhaps maybe unnecessary. I'm sure you guys have heard lots and lots of stuff about HPV. This is a talk with an agenda, so let me be honest about that. The CDC gave a grant to the National AHEC organization. AHEC Area Health Education Center, Maxine Golub and Dr. Kallman are integral to that organization in our state. And this is an agenda to try to increase HPV vaccination rates. So there is this is not your average scholarly talk about HPV, although we will cover some of the scholarly aspects of it. I would like to remind you, because it's a grant-sponsored event, these evaluations are really important. If you don't fill these evaluations out, they'll kidnap me, take me to Atlanta, and beat me to a pulp. So please fill out these evaluations, and they're on the table outside, or we can pass them around. All righty, let me get my timer rolling here. So you are the key, not you necessarily, but you and everybody else. You are the key to HPV cancer prevention. And the goal of this, the point of this, is that we as physicians, as family physicians particularly, since our shtick is prevention, are key to increasing these vaccination rates. As we'll see, HPV vaccination has been somewhat sluggish in its uptake. And so we will talk about ways that we can increase that. I don't have any disclosures of relevance. We'll talk a little bit about the importance of HPV vaccine, the rationale for vaccinating at 11 and 12 years old. I'm sure you guys, as I do, get questions about why do we have to worry about this when I don't even want my child thinking about sexual activity. What are the recommendations for HPV vaccine for girls and for boys, and clarifying some of the recent changes to the ACIP recommendations, which can be a bit confusing. We'll talk about how to talk to parents about HPV vaccine, and give you at the end some resources that you can look at down the road. So HPV, lots of different viral subtypes. The ones we're mostly concerned about cause mucosal infection. So we're not worried about the finger warts, the nose warts, Wicked Witch of the West sort of stuff. It's mainly the mucosal stuff. As you recall, the high risk, the oncogenic ones, are the ones associated with cancer. The most prominent non-oncogenic ones, HPV 6 and 11, which are covered by the virus, are associated with warts, laryngeal papillomas, those type of things. And we'll see the composition of the vaccines vary somewhat in how they cover these. It's really, really common, HPV infection. Most males and females will be infected with at least one type at some point in their lives. Lots of statistics there about the prevalence of it. And remember that most people don't know that they're infected. So we have an opportunity for prevention because most people don't have symptoms of something going wrong. I will take, because these are sort of canned slides from the CDC, I feel an obligation to make fun of them when I can, and this is one of those that, I guess clocks help some people understand prevalence, but one case every 20 minutes of a cancer caused by HPV. This is an interesting slide because it talks about the number of cancers caused by HPV out of the total proportion of cancers in each of these sites. So for instance, anal cancer, 4,000 cancers per year caused by HPV is about 91% of the overall cancers. So do the math, proportions, cross products, 4,500 something total cancers. The point of this is that most of these cancers are caused by HPV. So we have a firm link to HPV and a real opportunity to try to interrupt some of that cause and transmission if we can. If you notice, there's with the development of the male recommendations for HPV, there's lots of question about whether or not there's men had a lot of HPV disease. And you can see the bottom numbers here, which are also reflected in this slide. It's the same order of magnitude. There are definitely more HPV-associated cancers in women, but 9,000 versus 17,000, same order of magnitude. In men, it's mostly oropharyngeal cancer, and the rates of that are climbing among men, largely due to change in sexual practices. Contributions of alcohol and smoking might help with that too. So cervical cancer, the most common HPV-associated cancer amongst women, 11,000 new cases and 4,000 attributable deaths in the US. Globally, it's much more of a problem. So there's lots of discussion, Lynn and I were just talking about the role of HPV vaccine in a society that's had a really good cervical cancer screening element, like in most developed societies, versus its utility in global areas. And I'm not sure I have a real answer for that particular conundrum, but it's a big problem wherever you go. 4,000 attributable deaths in 2011 is in the setting of a active cervical cancer screening strategy. So we still have room to improve. Is it the question that Lynn and I were talking about is it worth the cost of the vaccine? And that's perhaps an issue that we won't settle today. Most cervical cancer, or many cervical cancers, occur in women between the ages of 20 and 44. So it's not necessarily an old people's disease. It's often a very young person's disease. So we need to be aware of that. This is the state map, in case you are all from different states. I don't know how many of you are from outside the city. My home state of Virginia, is holding the line for we're not giving nobody our data. I'm so proud. But you see New York, we're winning, along with a number of other states, Texas, Florida, large states, with a high prevalence of HPV-associated cervical cancer. And the banner says all that. Rates by race and ethnicity, so these are incidence rates by race and ethnicity, commonly affects African Americans and Hispanics. In terms of disparity amongst cervical cancer deaths, African Americans are disproportionately affected, we think largely because of access issues and follow-up once diagnosed. So there are issues with that, but there's certainly preventable opportunity here. And if you look at the annual burden of HPV, so without screening, so this is the difference we can make by adding vaccination. We can prevent 3 million cases of cervical cancer, 3 million cases of cervical cancer and precursor, as well as $7 billion of healthcare expenditure related to cervical cancer and cervical dysplasia if we were to vaccinate with a high rate of efficacy or uptake. If we talk about the national status of cancer, the oral cancer rates are increasing. And we see that many times in men. Anal cancer rates are increasing. Vulvar cancer rates are increasing, and penile cancer rates amongst certain subgroups. So the HPV effect, the impact of HPV disease seems to be increasing. And the CDC talks about that as another reason to get ahead of the HPV vaccination argument. Now, is it a convincing sort of evidence-based medicine reason? Not yet. But I think preventive services are in that gray zone a little bit. And I can say this as somebody that teaches evidence-based medicine, where we often don't have the evidence for the next preventive opportunity. We need to develop the evidence. We need to be very careful that we're not wasting money and throwing money at things that don't actually work. But this is some of the driver for pushing HPV vaccine, even in the absence of firm evidence that it helps reduce HPV or HPV cancer. one of the thrusts of this campaign is to talk about HPV vaccination as cancer prevention. And that's intentional. It's to try to get it away from the idea of HPV as a sexual issue. It of course is, and the CDC is not telling anybody to lie about it, anything like that. But we want to frame it as a cancer prevention issue to make the conversation go slightly easier. This lovely young girl is thinking, I really don't want a vaccine. That's a calmer reaction to the notion of vaccine in 11, 12-year-old than I usually get in my office. I don't know about you guys. Usually it's screaming and carrying on. The HPV vaccine itself, kind of interesting for those of you that are kind of turned on by microbiology. It is the capsid protein is the antigenic part, the L1 capsid protein. And what they do is they create something that looks like a virus, a viral particle out of just this protein. So there's no opportunity for actual infection. And it doesn't, it's in and of itself cause cancer because it doesn't have the viral replicating machinery in it. It's just a particle that looks like it. It's like the envelope around a letter. And it's kind of cool. I visited the Merck plant to see the Gardasil factory. It's this enormous sort of, it's like beer brewing, but more scientific. There's just these large tons of HPV vaccine floating around, and it's a fascinating process. These virus-like particles actually produce a lot of immunogenicity compared to other ways that we do things, individual proteins that are circulating around, largely probably because of that particle effect, if you're interested. So these are the different vaccines currently licensed. We have the 2-valent or the bivalent HPV vaccine, which concentrates only on the oncogenic types, HPV 16 and 18. Quadrivalent, the HPV4, which has both the 6 and 11, the non-oncogenic types associated with warts, et cetera, and 16 and 18, which are the oncogenic types. And then the 9-valent, recently released, covers more of the oncogenic types, all the 30s through 50s, the 5 additional ones. And we'll talk about the proportion of disease caused by those in a second. Contraindications, you can kind of see laid out here. The latex sensitivity for Cervarix has to do with the individual syringes, not the multi-dose vials. The hypersensitivity to yeast is because the Gardasil vaccines are grown, I told you it was like beer brewing, they're grown on yeast and filtered out that way. And then you see the difference in the dose series here, 0, 1, and 6 months for Cervarix and 0, 2, and 6 months for Gardasil. This is the comparison about kind of what they cover in a easy, fairly pretty graphical format for you. And the notion of adding the 5 additional antigens to HPV vaccine is to cover an additional 15% potentially of cervical cancers. When we look at the attributable risk of cervical cancers for different HPV strains, we get another 15% there, so for a total of roughly 81% coverage. So again, reasonable preventive opportunity there. I forgot this was progressive disclosure. HPV recommendations, we're going to go through this a little bit sequentially because this is sort of the previous recommendation you've heard, and then we'll cover the updates. You can start HPV vaccination as early as 9 years old for both girls and boys, and the goal is to finish before the 13th birthday. Again, debut of sexual activity being younger and younger these days. As a parent of teenagers, it stresses me out. But this is the goal, is to get the series completed before the onset of sexual activity. You can catch girls up between age 13 and 26 if they haven't finished. You can catch boys up between 13 and 21. HPV vaccine for routine immunization, routine vaccination is only approved or recommended up to age 21 in males unless they are at increased risk of immunocompromise. There are men who have sex with men, those indications. And we'll cover that again. So it's routinely recommended, again, for everybody. And the bottom of the slide here has the chant that I think the CDC wants you to say in your sleep. The clinicians should recommend HPV on the same day and in the same way. It's a nice sort of, rolls off the tongue, as the other vaccines for preteens. I know in my office, as the school-based immunization or the school requirements for immunizations come up, we get parents showing up for the Tdap vaccine, maybe the meningococcal vaccine, and almost never do they kind of present for the HPV vaccine. So it's been a real struggle to get if they're coming in for nurse visits or well child visits, to get the attention for those other two vaccines, especially HPV. The updates to the HPV vaccination to incorporate the 9-valent HPV is routine vaccination 11, 12 years still. That's the target group, although you can start it as early as 9. Recommended through age 26 for females routinely, 21 for males routinely, and men through age 26, men who have sex with men or immunocompromised, including HIV infected. Now, what do you do when you have HPV stock, HPV4 stock, HPV9 stock? How do you work that out? What they want to kind of get across here is that 16 and 18, the two most prevalent oncogenic strains of HPV, are covered by all the different vaccines. Yes, there's additional benefit from the 9-valent HPV, and we want people to get that. But if you're running out, if there are inventory issues or whatever, just give them some sort of HPV vaccine. That's frankly the recommendation. For females, and that depends on gender. For females, any HPV vaccine product can be used to continue or complete the series. You don't have to go back and complete it all with 3 doses of 9-valent or 4-valent. Whatever you started, just give any HPV vaccine. For males, only 4-valent and 9-valent are approved in males. Cervarix is not approved in males. So you're going to be using one of those two. Timing-wise, just remember the timing should be, interval between doses 1 and 2 should be about 6 weeks, 1 or 2 months, depending on the product you're using, and you need at least 6 months between the intervals of the first and third. But as I'm sure you know, you don't need to restart the series if you're getting somebody late. Just go ahead and complete it. It's safe. We'll detail some of this later. It works, and it lasts. The HPV immunity, the cohort studies that are looking at HPV immunity specifically show that it's lasting at least 8 to 10 years, we'll talk about. Vaccine safety. So CDC is well aware that there are many, many, many concerns about HPV vaccine safety. And so I think it helps us to know how the CDC is looking at vaccine safety so that you can explain that to your patients. So this is one of the worst slides that unfortunately covers very important information. These are the two major ways that the CDC looks at vaccine safety. The Vaccine Adverse Event Reporting System. Who has contributed to VAERS at some point in their life? That's great. I'm glad. Try to spread the word. So VAERS is one of the principal ways that the CDC conducts what's called passive surveillance. They wait for reports from providers of problems with vaccines. And these can be anything. It can be, I felt a little woozy after a vaccine, to I fell down, had a seizure, whatever. So have a low threshold if you can. Try to make it easier on yourselves to report to the VAERS, because it's really important that we get these sort of things in. So these are signals from the whole population of the U.S. where we get ideas that things may be going on with vaccines. It covers all vaccines. They're trying to make it as easy as possible to report. There's online reporting, there's paper-based reporting. Try to really work on finding a way to do that. If you type VAERS into Google, you'll find the reporting system. The Vaccine Safety Data Link is more like active surveillance. So what this is a group of large sort of health maintenance organizations, Kaiser and Group Health and those type of large health maintenance organizations that have an electronic health record that covers a large amount of population. It's a relatively closed system. So there are a bunch of these around the country that have all agreed with the CDC to monitor and get data about vaccines and disease outcomes and such. But to complement the passive surveillance of VAERS, they routinely do sort of cohort studies, retrospective cohort studies on vaccines to see if there's real problem with a vaccine. One of the limitations of VAERS is you're not getting population-based data. You're getting sort of individual reports about vaccine safety. With the Vaccine Safety Data Link, you have the whole population of all these different health maintenance organizations, and you can compare rates in a reasonable way to really determine whether there's an association between vaccines and adverse events. So they work complementary. Vaccine Safety Data Link has about 9 million people, and it's been very useful to ferret out some of these issues of vaccine safety. So the ongoing safety monitoring from HPV has shown that most events are non-serious. non-serious are things like are either things that aren't directly related or pathophysiologically kind of don't make sense, or they're very small, sort of tiny local reactions, pain that goes on for a certain amount of time. But they have a pretty low threshold for covering what would be a serious side effects. And headaches, nausea, vomiting, fever, those things count as serious side effects. So they're not skimming the top of this a little bit. And so those are the serious side effects. Syncope continues to be kind of an issue. Is that an issue of giving a vaccine at all to an 11 and 12-year-old? There's probably some of that. Just in general, the pain and emotional turmoil associated with vaccination at that age may cause that. And they do still recommend this 15-minute observation period after vaccination to just ensure that people are safe after that. This vaccine safety data link allows this rapid cycle analysis. So what they looked at after about 600,000 doses of HPV4, looking when a lot of this controversy about the safety of HPV4 came out, they looked at those vaccinated versus unvaccinated and tried to figure out if there's a real association with vaccination with some of these worse adverse events. Looked at Guillain-Barré syndrome, seizures, all these different serious side effects, and found no significant increased risk. So 600,000 patients is a decent population, so I think we can feel somewhat comfortable about that. Ongoing, they're continuing they watch VAERS for this, in this passive surveillance way, for reports of potential vaccination adverse events. The vaccine safety data link, the two projects they're looking at most now is the safety of HPV4 amongst males and also inadvertent vaccination during pregnancy. They're continually running data through the vaccine safety data link project on those 2 points. And then, should they get a number of reports from VAERS about a particular concern, they would set up a study in the data link to cover that. And the CDC is not is certainly willing to run reports of any concerns shown in the media. So if there end up being media reports or social networking reports or whatever of problems about the vaccine, the CDC can relatively quickly get into the vaccine safety data link and run that data and see if there ends up being an association. For non-CDC vaccine safety activities, so things that are happening outside the CDC monitoring vaccine safety, there are these post-licensure commitments from the manufacturers. So the manufacturers are required post-licensure to monitor reports of vaccine side effects. There's a vaccination and pregnancy registry. Apparently the Nordic countries are doing something about long-term follow-up, again, largely because they have the electronic records that are shared across the country, and you're able to grab that sort of population-based data. The World Health Organization did a review of vaccine safety. The Institute of Medicine did one on adverse effects of vaccines, and all of these showed that there weren't any major safety concerns, and the minor safety concerns they were manageable. So no risk of venous thromboembolism following it, no risk of autoimmune neurologic conditions have been found, and while there is some association with 4-valent HPV of some localized skin infection within 2 weeks after the vaccination, and then the syncope, no major safety concerns were found as part of that. Syncope and anaphylaxis came out as potentially linked in the Institute of Medicine review, where there is some association between a vaccination and anaphylaxis. There's an association between injection of not just HPV vaccine, but any vaccine, and syncope. So again, these shouldn't be surprising to us. We know that if we inject something into somebody, we are at some level risking anaphylaxis. It's not necessarily found to be that much bigger for HPV vaccine than other vaccines. So we need to kind of keep that in mind. And then they looked at other health events and didn't find an association. What is the CDC doing for 9-valent HPV vaccine? Lots of pre-licensure studies covering 15,000 patients, so decent numbers. But again, with the post-licensure commitments and the other vaccine safety recommendations are still in effect. We're seeing very similar side effects to 4-valent HPV, the local site reactions, syncope, those type of things. Impact. So as somebody that teaches evidence-based medicine, I'm constantly, Alex knows it, I'm constantly yammering at people to look at outcomes and more like patient-oriented outcomes, morbidity, mortality, those big-ticket outcomes. That ends up being a bit of an issue when you're studying HPV vaccine, and we'll talk a little bit about that. But it's important, and I think the ACIP, the group that decides on these vaccines, the Advisory Committee on Immunization Practices, has largely as a result, by the way, of family physician influence. The chair is John Tempe from Wisconsin, who has really pushed a way to the grade system of grading vaccine evidence, really concentrating on specific patient outcomes, not merely vaccine immunogenicity studies, vaccine effectiveness studies that rely on antibody levels and those things, but really pushing the patient outcome data. But it's a slow process. We have to develop systems and push requirements for the manufacturers in to develop that sort of data. So here's what we have so far for HPV. Let me divide this also into early outcomes. So the HPV prevalence, kind of a proxy outcome, but an outcome of interest. Genital warts, those are kind of the early outcomes, the things that might change easily on introduction of a vaccine program. The middle sort of outcomes, taking years to decades, might be the dysplasia and precancer changes. And then the late outcomes, and the real thing we want to affect the most is the HPV-associated cancers, but that's going to take a while to be able to show that effect. So when we monitor impact for HPV, we look at post-licensure evaluation to see what's actually going on in the wild when we give these vaccinations. So there has been population impact for the early and mid outcomes. So primarily the dysplasia rates and the vaccine effectiveness rates. Genital warts is a big area of study. So we've looked at that in several countries, HPV prevalence and the dysplasia lesions. National Health and Nutrition Survey looks at HPV prevalence through cervical vaginal swabs. So as part of this examination for this study, they actually did swabbing, found already the impact of some HPV vaccination at reducing prevalence of HPV by 56%. And the other age groups who presumably had not gotten vaccinated didn't show a difference over time. So they come up with a vaccine effectiveness rating. Great. What about, so this is more data about that. And you can see the purpose of this slide is to look at the age ranges that would have been vaccinated. The 15 to 19 in 2024 age ranges, you're beginning to see a decrease in, this is anogenital wart prevalence. You don't, and maybe in the 25 to 29 range, you don't see that for the unvaccinated cohorts as much. Another Australian one looking at genital warts at first visit. You see the greater than 30-year-old age group, not vaccinated, more than likely, doesn't have the same sort of decrease in prevalence as does the vaccinated cohorts, less than 21 and 21 to 30. And this seems to be working for both males and females. A systematic review looked at the population impact. So it looked at combined 20 studies in the high-income countries, looking at the overall coverage. And when there's decent coverage, over 50% coverage amongst the target age group, we can see HPV 16-18 prevalence, again, just prevalence, decreasing by 68%. Warts are decreasing. So these early outcomes are really changing. There's some evidence of herd effect, that herd effect, if you recall, is if we don't have to get 100% coverage, it reduces the rate of prevalence, or reduces the prevalence rates all over, just by decreasing the amount of HPV in the population. And there's some evidence, early evidence, of cross-protection against other types. So this is still pretty tentative, but there's some evidence of that. This is the slide that talks about, for all the EBM fanatics, of which I am one, about why we can't get that population data yet, and realize what's going on with cervical cancer screening. So if we're why don't we have HPV vaccines evidence that looks at cervical cancer death? Well, we early on showed the difference in sort of global mortality from cervical cancer versus U.S. mortality, much different, right? So we have a relatively few cervical cancer deaths in the U.S. Cervical cancer itself is detected through screening. And because screening recommendations have been changing in terms of frequency that we're doing them, we have less overall data to be able to conduct a study like that, right? If we don't have as many outcome data points, it's harder to find differences that might be there. We don't have a great cervical cancer screening registry apparatus in the US other than the Vaccine Safety Data Link, so we can't monitor things like that. Some socialized countries, the Nordic countries, Britain, those type of things might have more capability for looking at that. And we don't have a real link where we do have data. We don't have the great link between the vaccine administration and the outcome of cervical cancer. So these are some of the difficulties we have getting the evidence that we'd like to see. We do have some evidence, cohort study-wise and others, that show that it looks like, if you recall, the vaccine particles are very immunogenic, and they're probably more immunogenic than the actual infection with HPV initially. And what we're finding is this evidence of immunity, the antibody levels mainly, is persisting for about 8 to 10 years. So it seems to last for a while. We're looking to see how far it lasts. This is the problem we're dealing with in the United States, where we have decent coverage, above 50% in Australia and the United Kingdom, less so in the United States, and all relatively high-end countries. So this is the conundrum we're dealing with today. And these are the different vaccines that would come up for this age group. Tdap and MCV4, the meningococcal vaccine, reasonable coverage, 70 to 80%. One dose of HPV, that's the green line, gets above 50%, so we're kind of happy with that. 3 doses, a full vaccination series for HPV, decently lower, right? For boys, the rates are accelerating, and again, we have the easiest time getting at least 1 dose in. Completing the whole series has been a challenge for both genders. And this slide is an interesting one because it talks about, this kind of points the finger at us a little bit as providers. These are missed opportunities. A missed opportunity is defined as a visit in which you gave another vaccine. So it's not as if you're dealing with a stubbed toe and forget to give a vaccine. These are visits where you're thinking about some sort of vaccine and you don't give an HPV when it's indicated. So the attributable risk or the potential for prevention here is we could get about 91% of people vaccinated if we rolled our HPV vaccine into our routine thinking. And that's what the impression is about the problem, is that we're not, as providers, rolling it into our routine thinking about vaccinations. Save you the difficulty of finding New York. We're over here at just initiating vaccine series immunization, so few were above 50%, but still an issue. And you can see there's a wide variety of how well vaccine series initiation is covered from state to state. So how should we talk about this? What are the ways that we can talk about HPV vaccine with our patients that kind of frame the conversation in a healthier way, frame it in a way that avoids some of the frankly arguments we have the potential for getting into with our patients when we talk about HPV vaccine? This is also pretty telling. So this is a study that looked at that asked the parents their estimate of the value of individual vaccines, and then asked the doctors, in a blinded fashion, what they thought the parents would say about the value of the individual vaccine. And it's pretty clear that we think our patients don't value HPV vaccine. And we're worried about flu too, by the way. And yet our patients are just as worried about it as every other vaccine. They place just as much importance, just as much value on HPV vaccine as they do the others. So when I say that, it's hard to talk to providers and go, we're the problem, but it appears that we are some of the problem. We need to be able to talk about this in a way that convinces our patients that we really care about this. So a couple of issues that they want to push is that they want us to make the CDC wants us to make bundled recommendations. These are the vaccines due for your child at this time. And there's several different ways that we'll talk about to do that, but also directly address the patient's concerns and questions and the parents' concerns and questions more often. Because just assuming they think one way, clearly we understand doesn't work. So making an effective recommendations. This is the same day in the same way chant that we're talking about. make recommendations in the same way that you would recommend Tdap and Chicago vaccine. You are due for 3 vaccinations today. I'll send the nurse in. That sort of delivery. And recommend it today. Don't by treating it differently, the patients can detect how any sort of hesitance. And if we treat this vaccine differently, we can expect some resistance to it. And this is again pointing the finger at providers, but I think we have some culpability here. And we found the same issue in, for instance, colon cancer screening, that patients say that we don't recommend it. Now, whether we actually recommend it and they don't hear us, or whether we don't recommend it is kind of a moot point, because either way, they're not getting the recommendation. So we have to work on our strategies about recommending these things, preventive activities specifically. And the strong recommendation from you is a principal reason why patients decide to vaccinate. Same with colorectal cancer screening, other preventive interventions. And this has implications for how we do our medical home stuff, right? Because we talk about medical home stuff as, well, each provider should operate at the top of their license. So I'm going to see all the train wreck, diabetic, cholesterol, hypertensive, heart disease people, and my mid-level providers or somebody else and my nurses will take care of the well stuff and the easy well stuff and the protocolized routine health maintenance visits. This suggests that we can't fully hand that over and not talk about it with our patients anymore. We have to be the ones, as the physicians, to deliver those recommendations to our patients because we have that relationship and we have that trust, and it's important. Some parents just need reassurance. So they've heard lots of stuff about it, and they just they're willing to go with it, but they need the providers to say it's okay. Some parents may be interested in vaccinating but have questions. Getting that reassurance helps, but it's important also to ask about exactly what they're concerned about, because even with a little bit of information, you can begin to address that, and that's part of the point of this presentation, was to at least review that safety data so you have something to say when they ask you about, well, I'm not sure, I want to kind of see, I'm worried about that weird walking video where the girl was kind of stumbling down the street. You can begin to address that sort of thing if you have just a basic amount of knowledge about vaccine safety. So examples here. Sophia is due for 3 vaccines today. These will help prevent meningitis, HPV cancers, and pertussis. I'll send the nurse in, right? Why does my child need this vaccine, if that's the concern? Well, it's very important. I know we'd like to protect Maureen. Her name was Sophia a few minutes ago, but I know we'd like to protect Maureen from cancer, and I'd feel better if she got her first dose of the HPV vaccine today. Try to push the today, in the same day, in the same way, right? My daughter will wait for marriage. My daughter is good. She won't have sex, ever. And you guys know this as well as I do, right? But so we gotta emphasize the prevalence of HPV. We gotta emphasize vaccinating prior to onset of sexual activity. I'm not sure I would go, she could catch HPV from her husband. I think that's a tough one. I'm not sure I would say that exactly. But anyway, if your main concern is why now, let's wait until the child is older. Well, what are you waiting for? And this is an interesting one, and I learned this from this presentation. The actual response to the immunization is more robust in the 11 to 13 age group than it is in later age groups. I don't know why particularly, I'm not sure we know why, but the actual vaccine immunogenicity is higher in that younger age group. HPV vaccine will be a green light for sex. Asking about suicide will make people want to kill themselves. You can kind of relate it to those type of things, right? There are a lot of interventions, a lot of sensitive issues we talk about in medicine. Virtually none of them have been shown to, just by asking about it, about vaccinating against or whatever. And there's actual study going on about the fact that vaccination does not increase the likelihood of sex or sex at a younger age. Would you give it to your child? So I know, for you, introduction to clinical skills people that really worked hard on that, you were taught never to kind of share personal information, those type of things. Well, this is one of those that I think in our relationships with our patients we can go over. Yes, I gave it to my child, grandchild, whatever, or I would give it to my child. I think that these messages, the personal connection here is important, and you can get that. If the main concern is side effects, You have to be honest. The vaccines have side effects. They all do. Medications have side effects. The aspirin they took this morning can have side effects. The ibuprofen they've been taking for 3 days straight has a side effect. Okay, you can reassure them about the severity of side effects, the limited time nature of the side effects, and move on from there. Effects on fertility is another one that's come up. This is an interesting twist, and I would recommendation about treatment for cervical cancer. There's some data that I know of, and we can talk about this more, that that treatment for dysplasia has been found in some studies to increase the risk for adverse pregnancy outcome. And I'm sure that that's a bigger literature that I'm not expert in, but I know that there's at least some suggestion that that's an issue. And so that's an interesting way to be able to talk about this, that if you get HPV disease, the treatment can be worse than the prevention in some sense. But otherwise, there's been no effect on fertility from the HPV vaccine itself that we found. And then before leaving the exam room, remind parents when to come back to work. Sophia is now Robert. I don't know what that. Robert needs the full HPV vaccine series, so please make sure to make appointments. So this is true for smoking cessation. Most preventive interventions schedule follow-up. If you remember the 5 A's of smoking cessation, that last one is arrange follow-up. You have to, your arranging follow-up demonstrates the importance of a preventive activity. So getting people back in, making sure that they're coming back in for the completion of their vaccine series is important. All right, we are at the review questions, and I have done so well that we're going to have lots of time for questions. All right, so HPV, so this is the audience participation section. Don't worry, it's easy. HPV vaccine is recommended for the following persons: adolescents at 11 and 12. Guys on the video teleconferencing system, I'm counting on you to answer these correctly too. All adolescents at the 11 and 12-year-old visit, females at 13, males at 11 and 12-year-old visit, females only at the 11 and 12-year-old visit. What do we say? A. Look at that. That turns blue. Excellent. All right. Should males receive the HPV vaccine? Why should males receive the HPV vaccine? Prevention of 16, 18, 6, 11, 16, and 18. Prevention of genital warts, prevention of anal cancer, or all of the above. I hesitated too much and gave you that answer, didn't I? All of the above. All right. Which of the following HPV vaccine recommendations is the most likely to be successful? Ask the parent if the child is sexually active. You don't do that? I'm shocked. And then they discuss the importance of HPV vaccine. Tell the parents their child needs 3 vaccinations today to prevent meningitis, HPV, cancers, and pertussis. Tell the parent about the vaccinations that are mandatory for school entry. And oh, by the way, would you like an HPV vaccine too? With that, you wanted that emotional layover there too. And ask the parent if they want HPV vaccination for their child, or wait till they're older and sexually active. B. All right. Okay, you guys are tiring of this. All right. So a couple other resources here. So the title of this talk is "You Are the Key." You are the key. Everybody is the key. Where do you get resources and information for this? There's lots of continuing education stuff, this presentation being one of them. Medscape, apparently the CDC and Medscape have gotten together and made a bunch of videos if you are interested in that. Lots of fact sheets available from the CDC where you can get information about this. If you recall, this girl's now looking the other way. She's still uncertain though, clearly. Lots of posters to put up around to initiate discussions in exam rooms and waiting rooms. And you can always email those guys. They provide speakers for grand rounds, sort of like this one. And there we go. You are the key. # we can stop HPV.